Good afternoon, everybody. Welcome, and we are looking forward to our PMS virtual conference session, Spotlight on GI Issues. Now, in the meantime, a word from our sponsor.
Our mission at Jaguar is to accelerate breakthroughs in gene therapy for patients with severe genetic diseases.
With gene therapy, we can give the opportunity at a better life. That's what makes Jaguar special.
For those of you I haven't met yet, I'm Kate Still. I'm the Scientific Director of PMSF, and this is our second scientific session of the We Are Family Conference. And I wanted to start today's session by acknowledging that the PMS community has been experiencing loss, both recently and in past years. And we just want everyone to know that we as a foundation are listening, we're here for you, and we're constantly carrying you in our hearts and minds. If you have any questions, any concerns, or you're just looking for support, please email info@pmsf.org at any point. And speaking scientifically and medically, it's our goal to be committed to you, to bring you information that can help get you through the day, but we're also very committed to long-term acceleration of research to better understand PMS and better treat PMS in the future. So this session is focused on GI disorders in PMS, and we know this is a concern for family members, not only in PMS, in the PMS field, but also in many other neurodevelopmental disorders. So we're excited to dive into that today. So without further ado, I would love to introduce our first speaker, Dr. Billy Bennett. He's a pediatric gastroenterologist and an associate professor of pediatric urology at Indiana University School of Medicine. His clinical research intersects computer science and how it can inform medicine. He's a PMS dad to his beautiful daughter, Cecilia, and his family is active in the PMS community. Dr. Bennett is also on our scientific and medical advisory committees, and he has advised us on many projects, most recently the NIH-funded conference CANDID, which we'll talk more about today. Welcome, Dr. Bennett.
Thank you very much, Dr. Still. So I'm very excited to talk about my favorite topic, which is poop and things related to poop. And so let me just get into the sort of first topic here, which is a topic I talked about a couple years ago. So I'm going to steal some of the slides from that, but I wanted to provide an update on some of the new research we have and some of my new thoughts, having spoken to many of you in the interim. So first, I want to tell you that my main motivation for doing all this is Cecilia. So she is 6, and she was diagnosed with PMS about 5 years ago, and she's had a lot of the same challenges that most kids have had, but also, like most of our children, she has aspirations to be a model, which we very much support. And her favorite person in the world is her twin brother, Silas. So the sort of things I want to talk about, first, I want to give you guys a sense of what the current medical evidence is for GI problems in PMS. And then I want to talk about a few common conditions that you may not be aware of, and the approach that I usually suggest people take with them. So first, as far as our current data on this, some of the stuff I'm going to talk about is pretty sciencey, so just kind of stick with me. I'll try to make sure that I explain it in a way that everyone can understand. So there's a few publications, just a handful, that have looked at GI problems. And this is one of the things that we're hoping to solve with the conference and the study that Dr. Still mentioned earlier, which was to really focus in on the GI problems in PMS. But as far as the things that other people have done, they're brief, small studies that we typically call case series, which means there's a dozen or two patients that participate. And in one small study by Dr. Kolovzan, they found about 40% of kids had reflux or constipation. At the last in-person conference, which I think those of us that were there remember fondly and wish we could get back to the days when we were allowed to do that. One of the sets of questions in green here was focused on GI problems, and kind of similarly, there was problems with constipation, diarrhea, that kind of stuff. But another big one was trouble with toilet training. So that's something else that hasn't been studied or reported in much detail, but the vast majority of PMS kids have delayed onset of toilet training for stool. The average neurotypical kid, boys, it's about 3 years and 2 months, and girls, it's about 3 years. My experience with PMS is it's more like 4, 5, 6 years, and sometimes never. In our personal experience with Cecilia is that she's capable of pooping on the potty, but she simply refuses not to because of the whole princess thing. And that, the behavioral side of stooling is really prominent among PMSers. In the family registry, which is a separate thing that asked a few GI questions but didn't focus on it hugely. We did find that there were a fair number, and so this is out of about 730 or so patients, and this is the number here is how many had these things. So just a few had some GI tests. The majority definitely did not. But it's something that, at least in my opinion, there's probably not enough attention paid to GI problems, as it really affects quality of life, which is one of the things that we're trying to answer with our current study. The other thing that's been published is that zinc deficiency, and don't look too much at this graph other than most of the patients, these are all PMS patients, most of them are in the black, which means that their ability to absorb zinc and copper is impaired to some degree. And we know that SHANK3, which is the gene that is missing in most cases of PMS, that it is important in absorption of zinc. So as I'll get into in a second, I usually recommend that that's something that people watch carefully. There's these fancy science fish, the zebrafish, and work by others. This is way beyond my understanding. This is what smart people do. Found that how long it takes for nerve impulses to move down the intestine was longer in the fish that had that SHANK3 knocked out. So what this tells us is that SHANK3 is probably really important for the way that nerves conduct signals down the GI tract. So we know that one of the reasons that people with PMS have many of the problems that they do is that the nerve signals aren't conducting like they should. And just like that happens in the brain and can cause things like autism and epilepsy, they also happen in the GI tract, and they can cause the stomach to be slow or the intestine to be slow. And that has a lot of consequences as far as symptoms. We also know something that's very important in our kids is that autism specifically, the majority of PMSers either have features of ASD or have been diagnosed with ASD. There is often a disconnect between what's happening in the GI tract and what the person feels. So there's an issue with what we call sensory processing. And if you don't sense that the lower part of your colon is filling up with poop, then you're not going to respond to it appropriately, and it's just going to sit there, and the cycle continues. And I'll discuss how that comes up shortly. There's another picture of Cecilia. She's in disguise though. So you don't know who this is. This could be Cecilia, it could be anybody. So the first disorder I want to talk about is something called cyclic vomiting syndrome. So this is something where we don't have any tests for it. It's just a pattern of symptoms. So it's actually a type of migraine that occurs much more often in children. It's fairly common among neurotypical children, but we think that it's significantly more common among PMSers. So what'll happen is you'll have, a few hours to a few days of intense vomiting over and over again, and then you'll go weeks or months without any symptoms. and there's no other explanation, no other medical problem, no fevers, no signs of an infection, that kind of stuff. And so the reason this happens is because of this thing called the vagus nerve that goes from the brain down to the GI tract. And it's actually the nerve that controls vomiting, appetite, nausea, lots of different things. So if it gets out of whack, if those nerve signals aren't firing like they should, then it can result in this vomiting signal that doesn't stop. And so what do? So the first thing to do in this situation is to give fluids. And in fact, that's usually the solution regardless of why somebody's vomiting. It sometimes helps to go to the ER to get these IV fluids. And a lot of times when you talk to ER doctors, they're like, well, I don't need to give this person IV fluids because they're not dehydrated. But that's not why you give it in this situation. You give it because it sends a signal to the vagus nerve and tells it to calm down. Zofran is another medicine we use frequently, or ondansetron is the same thing. And then there's some of the anti-migraine medicines like sumatriptan that can also be helpful. We also use medicines to help prevent an episode. So these are things that you give every day to keep an episode from happening. And then it's also important to avoid triggers that are usually specific to the patient. Car rides are a big one. Some kids it's different smells. Some kids it's getting upset. Some kids it's fighting with their brother. And the medicines that we tend to use. So I've talked to, I'd say, a couple dozen PMSers, and then I have 4 or 5 patients of my own who have cyclic vomiting, and amitriptyline is usually what we use. It's, if you read about it, it can be kind of scary, like it's this old antidepressant, but we're not using doses that are in that range. We're using tiny doses, 1/10 of what they used to use for things like depression. It rarely causes side effects at low doses, but it's actually pretty helpful at turning the volume down on that vagus nerve. Cyproheptadine is another one I really like a lot. It's also an appetite stimulant. So for kids that have low weight or aren't growing well and need to eat more, it can kind of help take care of 2 things at once. Propranolol is an old blood pressure medicine that people will sometimes use, and there's some supplements that can be helpful too. Another picture of Cecilia. I think this is right before she threw up because she also has cyclic vomiting syndrome. For her big trigger is motion. So if she's in the car, on a trampoline, even you're just running around a lot, then she can throw up a few times. So this next one is a big category of stuff. And the one that I think people are most familiar with is reflux, or GERD, gastroesophageal reflux disease. And this just happens because there's a muscle right here at the lower part of your stomach called, or the upper part of your stomach, the lower part of your esophagus, called the lower esophageal sphincter, or LES. And since PMS often causes low muscle tone, we often see low muscle tone here. And if that happens, then stuff just comes up from the stomach. It's just basic plumbing. And that's really what my job is I'm a plumber, and there's like one pipe, and it only goes one direction. So it all makes sense kind of physically. So the way that we diagnose it is with something called a pH probe. So this is something called a Bravo probe, which is this wireless probe that we place with a scope. It's got a little cool suction cup that sticks to the side of the esophagus, hangs out there for a couple of days, and then falls off. And while it's doing that, it's sending these signals to a little pager device that the patient wears, and it tells you how much acid there is, how much stuff is coming up, when it's coming up, how long it lasts. And we look at all those tracings and we can say, okay, this is a normal amount of reflux, or this is GERD, or there's what we call a pathological amount of reflux. So too much acid, which can cause problems. Treatment, the number one best treatment for reflux is something called a PPI. Anything that ends in prazole, so omeprazole, esomeprazole, lansoprazole, and they have really cool names like Nexium, Prilosec, and for those who don't know, there is a preponderance of X's and Z's in drug names, and I'm sure there's a reason for that. It makes it they just sound more exciting, but don't be fooled. It's all marketing. So this is recommended as the best choice by every GI guideline. Hundreds and hundreds of high quality studies say this works the best to keep acid medicine down. It's generally safe long term, but I avoid it in younger children, and then elderly people that have heart or kidney disease. It can sometimes make these problems worse. But the risk benefit for doing it in children tends to be way on the side of benefit if the reflux is bad. The older medicines we use were called H2RAs, or histamine 2 receptor antagonists. And these are things like Pepcid and Zantac. They tend to work fairly well, but they're not quite as effective. They also work a little faster, so they're kind of better for an as needed thing. But you can become resistant to them over time. So I barely use these medicines anymore. And you can always still use things like antacids, like Tums. Sucralfate, I have not found to be very helpful for anything. And then, of course, lifestyle changes are important. So spicy foods, high-fat foods, carbonated beverages, things that have caffeine in them, all are associated with worse reflux symptoms. As we all know, once you're grown up, you inherit some degree of reflux. Another common one that I think I've seen a lot more in PMS than is recognized. I've talked to lots of families who end up getting diagnosed with this, but basically what it is slow muscles in the stomach. Just like PMSers have slow muscles in the slow nerves in the brain, the nerves that work in the stomach can also be slow. And then that makes the muscles that contract it go slower. And so what happens is food just accumulates over the course of the day and stuff doesn't leave the stomach, which is obviously very uncomfortable. So the pattern there is typically vomiting that is worse later in the day or can happen in the middle of the night. And often they're throwing up stuff they ate for breakfast or lunch. We diagnose this with something called a gastric emptying scan. And this is something where you eat some eggs that have a tracer in it, and then you watch to see how much leaves your stomach over time. And the goal is you want to have about 90% of it gone by 4 hours. And if there's still food left after that, then we tend to treat it. Erythromycin is our drug of choice, by far the most effective and least likely to cause a problem. There's older ones called Reglan, which I don't use much at all. I try to avoid it, especially in kids that already have underlying neurological problems like in PMS, because it has a black box warning in children that it can cause dystonia or abnormal muscle movements. And I've seen it quite a few times and then regretted that I gave the medicine. So I admittedly, I tend to avoid it. We often use PPIs with the erythromycin in this setting because the PPIs also do something called improved gastric compliance, which helps it stretch. And then in rare severe cases, we'll use something called a GJ tube, and I'll talk about tubes here in a little bit. Low-fat diets can be helpful too, because the more fat you have in a meal, the slower your stomach is. And then less frequent meals can also help slow things down. And then functional vomiting is sort of our kind of catch-all for the things that don't fit into things like GERD and gastroparesis and cyclic vomiting. And it's sort of just everything else that causes vomiting where it's not in a clear pattern. And treatment can be more difficult in these kind of situations, but we think it's probably still issues with the vagus nerve and how it communicates with the brain. So we tend to use some of the same medicines that we used for cyclic vomiting syndrome. There's a picture of Cecilia from like 3 years ago when she dove out of her pack and play onto her face, and she's very proud of herself after doing that. So diarrhea is another symptom that a lot of PMSers have. The most common one is something we call irritable bowel syndrome. And it doesn't tend to get diagnosed in kids that have neurodevelopmental disorders like PMS. But my opinion is that a lot of the inconsistency in stooling that kids see really is a childhood version of irritable bowel syndrome. And really what it is where the colon can't decide if it wants to move too fast or too slow. It just doesn't coordinate well. And you'll often have constipation one day and diarrhea the next day. And there's a variant that we describe typically, usually in neurotypical children, called toddler's diarrhea, where they just get diarrhea all the time. And we try to do things like avoid sugar and stuff like that. There are some medicines that can help. Levsin and Bentyl are two that we use all the time to help slow down contraction of the colon. There's a newer one that's just approved for older kids and adults called Viberzi or aloxadoline. And that is a little bit more effective at slowing down the GI tract. You have to be careful with these kind of medicines, though, because it's really easy to swing back the other way. That's the big side effect of those things, is you can get more constipated. Diet is a big factor. And what we often do is something called the low FODMAP diet. So it's avoiding a lot of simple sugars. And there's a lot of healthy foods, like carrots don't have many FODMAPs at all. Apples have a ton of them. So that old saying about apple, an apple a day keeps the doctor away, that's not true. There's tons of sugar in apples. They aren't nearly as good for you as you might think. Some people try what's called the specific carbohydrate diet, which includes avoiding most sugars, and then some grains, because there's a lot of sugars that are contained in breads and things like that too, and then lactose containing dairy. There is the gut and psychology syndrome, or GAPS diet. So that's an even more restrictive, where you avoid starchy vegetables as well. Some people do the gluten-free diet. Some people do something called the Nemechek protocol, which is this sort of proprietary protocol aimed at patients with autism. There is very little evidence for any of this. And I generally don't think that it's bad to try a diet. But the main thing is that you need to do it under the guidance of a registered dietitian. Do not undertake any diet, especially in a child with special needs, without talking to somebody who is a registered professional who can give you scientific advice to make sure that you're not missing something that's an essential part of their diet. So here is a picture of Cecilia and her twin brother eating lots of simple sugars because they're delicious. And I don't remember how they pooped after that, but I guess we're not entirely, walking the walk. Constipation, probably the most common. In fact, our research suggests it is the most common reported GI symptom in PMS. And I'll show you those results here shortly. But constipation is a combination of a couple things. So the biggest contributor, I think, in these more complex neurological syndromes is that there's just not good tone and coordination of the nerves in the GI tract. So the colon is already starting out not making perfect poop. And so if it hangs around in there longer, then the result is the poop spins too long in the colon, it gets too dry, and then you get constipated. And then you don't want to poop because it's too hard, and then you get more constipated. But there's another big thing happening in PMS. And I will predicate by saying that this is mostly my opinion, but we're hoping to kind of put together a panel of wider experts on this and do some more research to see how true this is. I think a really big contributor to constipation is related to autism, and it's related to, and that gets in the way of how a person processes information from their body. So if the rectum is not distending, then you won't know you have to poop. But if the rectum distends and you don't get that signal, which is what's happening here, then I think that that's probably responsible for most constipation in PMS. So what do? Miralax is probably the most effective thing. It's easy to use. It's very, very safe. But there are other options that work nearly as well, like lactulose and mineral oil. They don't affect the nerves. They just keep the poop soft by making sure that there's plenty of water in it. They tend to work better if you use them regularly, and if you start out with a completely clean colon. I tend to use about a half a capful to a capful a day. There's also stimulant laxatives, which tend to interact with those colon nerves and give a push. So these are things like Senna and X-Lax, which is still Senna. Magnesium citrate's one, or lots of magnesium supplements work the same way. I often use them as a second medicine if the stool softeners aren't doing their job. These are also, tend to be pretty safe. Occasionally they can cause some cramping. I think rectal medicines, are helpful sometimes, but most people don't like them. And kids that already have issues with sensation in their in the way that their GI tract works, they're already not happy with how their bottom feels. So adding medicine to it sometimes can be an issue. But doing enemas or suppositories is sometimes a good way to get yourself out of a jam. No pun intended. I'm sorry, pun actually intended. Something that I want to add that people don't realize exists that is often very helpful is something called pelvic floor PT or pelvic floor physiotherapy. And this helps people be more aware of how the muscles are working in their GI tract or in the lower part of their GI tract that they have to squeeze and relax to poop. And so practicing using them can help you be more comfortable pooping, but also be better at it. So this is just like, training, like pooping training. And interestingly, most patients in pelvic floor PT are elderly women that have low muscle tone in their pelvis, which is very common, and often pregnant or postpartum women that have similar problems. So it's these very sort of distinct populations, but also kids that have hypotonia, kids that have low muscle tone and have trouble pooping. There's a lot of overlap between constipation and urinary symptoms because of that. You use those same muscles. And this is a diagram of what's called the pelvic floor. Other things that people will have done to look for constipation is something called a motility study, where we place this catheter all the way around the colon using the colonoscopy. And then we measure how well those nerves and muscles work. This lets us decide if somebody's a candidate for something called a MACE or an appendicostomy or a cecostomy. And these are all just fancy terms for a tube that goes directly into the beginning of the colon and lets you flush it out. So it's a way of giving an enema without having to put it in the bottom, and it goes the whole length of the colon, so it's more effective. I'll skip that one. The other kind of more rare thing that people need to know about is something called SIBO, or small intestinal bacterial overgrowth. So basically what happens is you've got about 1,000 bacteria in 1 ml of fluid in the stomach, about 10,000 in the small intestine, and only about 10 billion in the colon. So you can see the difference is massive. So if things are going slow, these bacteria in the large intestine can back up into the small intestine, and then they like to digest stuff. They make lots of gas. So if lots of bloating, then it's something where we would test for small intestinal bacterial overgrowth. In extreme situations where the GI tract is not working, especially the colon is not working, then we can sometimes do something called a diverting ileostomy, where we just disconnect the small intestine from the large intestine and just let it drain outside the body. And in cases where the whole intestine isn't working, then we can do things something called TPN, or total parenteral nutrition, which allows us to give calories through the veins. I do want to share some of my thoughts on how I think PMS is unique. So there are other things that are more pronounced in PMS that may not occur in other disorders or in neurotypical kids. And I think we're dealing with a combination of decreased pain sensitivity, which many, many people notice in their kids with PMS, altered sensory processing, which is often part of the autism spectrum disorder, and then also slow GI motility. So I feel that this often makes it very difficult to determine if children are in pain. And so I often suggest, if there's unexplained fussiness, changes in behavior, look for a GI cause. Constipation should be the first thing that's looked for. There's other disorders that have altered sensory processing, other genetic problems where they have similar sort of issues. So we do have to rely on parents' intuition. So if a doctor doesn't believe you, get ready to be dismissed, but you should trust your instincts. And I do feel like in these kind of situations where things are not moving well and nobody's listening to you, getting a consultation with somebody that does this all the time is often a good idea, like a motility specialist, which is a special type of GI doctor. Here's a picture of Cecilia with it's a blanket she got from the hospital. And she looks like she's cute, but she's probably going to demand, so right now she tells me to leave. She does not want me to do anything for her. So she just tells me, if she's taking a bath, she's like, Daddy, go away. So this is probably right before she told me to go away. Tubes are pretty common in lots of kids that have neuromuscular or neurodevelopmental disorders. So G tubes just go right into the stomach, and then you can just feed as if you were drinking it. It just kind of bypasses the mouth and the esophagus. So that's typically good for kids that have swallowing problems. So if you can't get enough down or you're aspirating, then that's when you need a G tube. A GJ tube is a modified form of this, and that's more for kids that vomit so much they can't keep enough food down. And so that's got a tube that goes past the stomach, and all that's internal. It goes past the stomach and into a little bit down the small intestine, so you can't throw things up whenever you're putting formula through that way. There are lots of different formulas people try, and I'm gonna kind of gloss over this a little bit in the interest of time and tell you that if you have questions about what kind of formula your kid needs, by far the best expert is a registered dietitian. They know far more about which formulas are out there and what's in them than I do. But just so you know, they generally fall into categories of standard formulas, hypoallergenic formulas, which are broken down a little bit, elemental formulas, which are completely broken down, blended formulas, which are like my new favorites. They have the same nutrition as standard formulas, but they get actual food and blend them up. And then people will sometimes do these blended formulas at home, which I don't recommend unless you've just got way too much time on your hands. There's this thing called a Nissen fundoplication that people will sometimes give for things like reflux. I tend to try to avoid that because the complications of it tend to be worse than how well it controls reflux. It can be very helpful in some situations, but this is something where I would not proceed with this unless you've talked to a gastroenterologist and they feel that this is absolutely the right thing to do. That being said, I've talked to GI doctors nationally who are very gung-ho about a Nissen, and I've tried to talk them out of it just because a lot of PMSers have told me about not having good results from it. There are certainly some that have, but I'm just saying enter into this operation with a lot of care and don't just jump into it because it's not reversible. Other general suggestions, kind of covering everything: avoid excessive antibiotics, messes up the bacteria in the GI tract. Avoid overuse of procedures if you can. Scopes and CT scans rarely give you a diagnosis. What you really need is somebody who knows what they're talking about. Don't go to the ER if you can help it. They are not, equipped or trained to deal with children with rare disorders who have chronic subspecialty problems. The biggest thing is to get referred to a specialist. Diet doesn't play as big of a role in children as it does in adults. Behavior plays the biggest role in children for a large number of these problems. Vaccinate any preventable or serious, GI diseases like, rotavirus and hepatitis both have vaccines. PMSers are way more vulnerable to infections. So making sure that you lower the chance of that is very important. And then there are lots of people that are going to tell you that they have a cure for some GI problem or another. And it's usually something that they're selling you. So just be very careful about things that are not based on medical evidence or science. My biggest concern is A, that you'll be out of your money, but B, is that we don't know if those things are safe because they aren't required to be approved by the FDA. Our children are unique. Remember that. It's not their doctors cannot treat them the same way they treat everybody else. And you're going to know more about PMS than the doctor will. Not all doctors are good. We've certainly seen doctors with Cecilia where we've not been pleased. And you have to keep pushing for the person that's right for your child and your family. And again, everything's a balance. There's some medications that have side effects, but you need them for, to help with something that can be even more dangerous. So really look at risk benefit when you're deciding on some of these therapies that I talked about. And here's a picture of Cecilia playing in the rain. Okay, so I'm going to do a couple slides just a little bit more specific. So my own experience with PMS, I have about 10 patients that have PMS here in Indiana. And I've talked to 100 or so on the phone nationally or internationally. And the kind of tidbits that I want to add are that, getting consultation from a GI doctor and and a GI motility doctor sometimes is often helpful. There can be weird things that nobody's going to be thinking about, like zinc deficiency. We've seen a couple cases of severe immune suppression and very low white blood cell counts because they had a zinc deficiency. And so it's easy to check for, easy to fix. Everything gets better in a week once you fix it. So we want to be aware of the fact that this is there's a higher risk for zinc and copper deficiencies in children that have PMS. We've had a few patients that have benefited from weird drugs that we don't use anymore. So there's something called cisapride, which really helps with kids that have vomiting that we can't get under control. It has to be monitored really closely, so it's just something to keep an eye on. And I see Dr. Still has come on to let me know that I'm running out of time. And then a few other kind of rare disorders that I've seen, I've at least heard about more often than I should in PMS that I think people should be aware of. And we'll give a quick plug for the CANDID study. You can go to candidgi.com and you can participate in the survey or register for the conference. It's open to families, clinicians, and scientists. And we're doing a GI survey that's kind of part of this conference, so we can gather some data ahead of time and know what's going on with our community. We have about 500 participants so far in the autism and neurodevelopmental disorder community. About 80 of them are PMSers, which is great. As you can see, most of them that have participated are older kids. Most of them are white. I wanted to know about hair color just to see how many redheads there were, and I was very sad to see that there's not as many as there should be. We're going extinct. PMS has been, of the specific disorders, has been the one that's participated the most, so I think that's great. But we have a lot of other folks that have participated, and we can see how all these things fit together. And then the final slide I want to show you is to give you an idea of just how prominent constipation is here. So of all the people that answered, constipation was by far, by a factor of 2, was the most common. But then a lot of other things happen too. This is really good evidence that GI problems are a serious source of suffering and lack of quality of life. And we need to do a lot more to understand it. And I think that's what we're hoping to do with the conference that we have coming up. And then I'll do one more picture with redheads, and then we'd be happy to take questions.
Thank you very much, Dr. Bennett. That was incredibly informative. We are saving questions till the end, and I see there's already a few in the Q&A, so we will field those at the end. So it is my pleasure to introduce our next speaker, Dr. Julia Dallman. Dr. Dallman is an associate professor of biology at the University of Miami. Her research is focused on how genes impact behavior, especially in the context of neurodevelopmental disorders. Her lab harnesses the laboratory model system of zebrafish, and she is the director of the University of Miami Zebrafish Facility. Dr. Dallman and her team were inspired to study GI disorders and PMS after attending the 2016 PMSF Family Conference, and they've been doing work in this area ever since. So your voice really matters. Welcome, Dr. Dallman.
Thank you so much for the invitation to talk to this community that has been so influential on what my lab works on. And I'm really looking forward to your questions and feedback. What I want to talk to you about today is what we've been learning from our zebrafish models of neurodevelopmental disorders, including Phelan-McDermid syndrome. And then work I've been doing with a clinical collaborator, Dr. Baharak Mushiri, to try to develop tests that might be able to give insight into GI symptoms that can be done at home. Okay, so my lab uses the zebrafish model to try to better understand symptoms in Phelan-McDermid syndrome specifically. And then we also have zebrafish models that have changes in SYNGAP1. And so we got into those two genetic conditions because of my experience in neurodevelopment. So I'm a basic scientist. And as a basic scientist, zebrafish are really a great model because they, this is a female and this is a male. They lay their eggs, and their eggs develop outside of the mom. And so you can watch development play out in a dish. And by 6 days of age, they're little autonomous beings who can eat food and escape prey. And all of those behaviors are very stereotyped, so that we can measure changes to the nervous system that might impact behavior and try to understand what's going on. And so to the right here is a movie of the zebrafish gastrointestinal tract. These fish were fed egg yolk, which they love, the high-fat meal, with some beads. And you can see these contractions in the GI tract that make the beads move through the tract from mouth, which is sort of in this direction, to the anus, which is in this direction. And this is the motility that that Billy was talking about, that Dr. Bennett was talking about, that's really important for digestion. We also study sensory processing symptoms. And to do that, we expose the zebrafish to changes in their sensory environments and then measure their responses. And we can map the circuits that are involved in these responses. And in this case, you can see this area of the hindbrain, which is actually where the neurons that make up the vagus, the motor component of the vagus nerve that Dr. Bennett talked about being really important for vomiting. You can see that this part of the brain doesn't respond to the stimulus the same way as in wild type animals. And this is the Shank3 or Phelan-McDermid model. And this is the publication about that. But today I'm going to focus on gut. And so when we, I think it was the 2016 Phelan-McDermid Family Conference that we attended with David James, who was a graduate student at that point. He's now a postdoc because he's left the lab. But we talked to families, and they were telling us about the big impact on quality of life of GI symptoms. And so we went back to the lab, and you can see that it's very easy to see these peristaltic contractions. And as Dr. Bennett said, you know, there's a hypomotility when Shank3, the copies of Shank3 are reduced in this model. So that the sort of hypomotility is very apparent in this model. So you can see that the movie is playing because every now and then this part of the gut contracts. And likewise in the SYNGAP model, again, the coordinated movements are not apparent going from mouth to anus. So this made it very clear that almost even more than some of the sensory phenotypes we were looking at, the GI was a very strong phenotype in our zebrafish models of Shank3 and SYNGAP. And in collaboration with Mason Klein, who's a physicist, he made us a program where we could align boxes along the gut and quantify the contractions so that you can see in this intestinal bulb, which is the equivalent of the upper intestine in us, you get, but so contraction wise, it looks like the stomach. So you get this churning movement, but once you get to this intestine, everything goes towards the anus. So these bright lines are contractions moving towards the anus, and they have a certain frequency. And in Shank3, that frequency is greatly reduced, but that frequency is not reduced in SYNGAP. So already we can see that the underlying basis of these two types of dysmotility in the GI tract are likely different. So here is the movie that I showed you earlier, where the wild type ant larvae were fed beads. And this is a Phelan-McDermid, this is a Shank3 model. And what happens is these beads, rather than propelling through the gut, get trapped at the junction between the intestinal bulb, which is sort of the equivalent of the stomach, and the upper intestine, just like Dr. Bennett was saying. So this kind of stomach emptying. And so we see this both in SHANK3 and SYNGAP models. So this is a little bit of a busy graph, but this is a zebrafish larva, and the different parts of its GI tract are color coded. So this is its basically its throat, stomach, upper intestine, lower intestine after pooping is in green. And listed here are the different genotypes. So this is wild type, SHANK3, and SYNGAP models. So you can see 6 hours after feeding the beads, the wild type animals have already started pooping. Quite a lot of the beads have been pooped out. But at this same time period, most of the beads are in the intestinal bulb of this model of both models of SHANK3 and SYNGAP. So what's going on? We know the fish are getting the beads in, so they're managing to take up the beads and the yolk. And one of the things that activates that motility in the gut is, so this is a diagram of the gut, and the pink are the smooth muscles that actually produce the contractions. And in green are the enteric neurons that Dr. Bennett was talking about. And in blue are the sensory cells of the gut. So these are called enteroendocrine cells, and they're kind of like neurons that secrete hormones. And they are what is sensing the food. So when you eat, there are specialized sensory cells in the gut that either sense sugar, or others sense fat, and others sense protein, and they release hormones that kick off these contractions of the gut. And when we found that there were motility deficits in the zebrafish models, we reached out to John Rawls at Duke, and Li Huaye at the time was a postdoc in his lab. These guys are experts in the intestine. And they had data that showed that a lot of genes linked to autism are actually enriched in these sensory cells of the gut. Okay, so we decided to look at both the sensory cells, which are in green, these enteroendocrine cells, and the enteric nervous system, because as Dr. Bennett said, if the enteric nervous system isn't working properly, the gut isn't going to move properly. And we stained the gut for neurons and the sensory enteroendocrine cells, and then did quantifications. And what we found was that the enteric neurons, at least they're there. We don't know that they're behaving properly, and certainly in the brain, we know that some of the circuits aren't actually functioning in the way we'd expect in the SHANK3 model, but the enteric neurons are there. What's decreased in our model is the enteroendocrine cells, and they're decreased in a manner that's dependent on the number of SHANK3 mutant alleles in the fish. So if we have sort of the haploinsufficient condition, the enteroendocrine cells are reduced some. And if we have a full loss of function in SHANK3, we lose even more of the enteroendocrine cells. And these are quantified based on their expression of serotonin. So believe it or not, serotonin is kind of known as the happy hormone. And your gut makes much more serotonin than your brain does. And it's these enteroendocrine cells that kick off motility of the gut they're actually a special subset that release serotonin, activate the enteric neurons, activate the muscle, and get that peristalsis going. So we wanted to know if this was specific to those enterochromaffin cells, or whether it was a general phenomenon in the all enteroendocrine cells. And what we found was complicated. So in the anterior intestine, SHANK3 model actually has more of these cells. And in the intestine itself, or the posterior part, there's a reduction. And it's a reduction of all of these different types of enteroendocrine cells in the posterior gut. So what could this mean? Well, it turns out that your gut has different functional regions. So in the anterior part of the gut, that part of the gut, those cells are all dedicated to nutrient absorption. While in the posterior part of the gut, you have different types of hormones that are released that feed back to coordinate these movements. So, so what we think is that the cells that are in control of motility are drastically reduced, while some of these nutrient sensing cells are as abundant or more abundant. So there's something affecting the types of cells that the intestine makes that alters its functional capabilities in the Shank3 model zebrafish. Okay, that's it for the zebrafish. And now I'm going to switch gears to talk about what we've been working on with my clinical collaborator, Dr. Moshiri, who's at Atrium Health, who's a motility expert, GI motility expert. So we had been reading the literature about GI distress being common in ASD, and this last summer we wrote a review looking at different neurodevelopmental conditions that are linked to a molecular diagnosis, and sort of compiling some of the literature on the GI symptoms that are common. And so this first circle lists a bunch of the molecularly defined forms of ASD with documented GI distress that were the motivation, where those communities were the motivation for the CANDID meeting. And Dr. Bennett was a huge leader in all of that. And I think I'm hats off to them for getting this going. One of the things that we found in our review is that about 6 of these genetic conditions have animal models. And in all of the animal models, there's a finding of reduced GI motility. So, so it could be that hypomotility of the gut could be a general underlying aspect of GI distress. And then many of these have validated zebrafish models. So we hope to get a better understanding of the symptoms by looking in some of these models. So some of the challenges to understanding GI symptoms, they remain fairly poorly described in people with ASD, and Dr. Bennett has done an amazing job with these surveys, getting more information. And some of the challenges that my colleague, Dr. Moshiri, and I were struck by was that the families caring for people with autism linked to de novo variants are worldwide, making concerted clinical studies difficult. Patients can be nonverbal and so have difficulty communicating symptoms. Partly it could be as simple as the way that those symptoms are sensed is different, as Dr. Bennett said. And then GI tests tend to require sedation or X-ray, or in the breath test, it requires eating spirulina, which at least when Dr. Moshiri gave it a go in an autism clinic, the kids would not eat the spirulina. And so we thought that maybe we could come up with a kind of simple test, which relies on blue dye that's put into muffins that are made gluten-free and match the egg meal that Dr. Bennett mentioned that's used for scintigraphy or the stomach emptying study. And while we were doing this, there was actually a group in England named, it's a company called Zoe that did a blue poo study. And they did it with thousands of healthy individuals where they ate blue muffins and looked for the blue poo and got a measure of how long it takes food to move through the gut. So this is the advantage of this, is it provides an objective measure, and it allows you to, it has the potential to allow kind of a low stakes test for how transit time through the gut is impacted by different sorts of interventions. And so what you can see here is that if you look at how long it takes food to transit through the gut, for most people, it takes about 1 day. Transit time is highly circadian, meaning, your gut sort of doesn't, you're not as likely to have bowel movements in the middle of the night as you are during the day. And if it takes over 3 days to have a bowel movement, well, that's pretty significant constipation. And in this large scale study, it was very rare to have transit times that were over 3 days. So this provides an approach that can be done at home. And so this is Dr. Moshiri. And so she sort of told me, anyway, so we developed these muffins, and we have a bakery that's making the muffins. And these are 2 children with SYNGAP whose families made the muffins at home, so we can provide the recipe. And
ready, Sissy? Here, open.
So that's a muffin without too much blue dye.
Hey, Michael.
This is a muffin that's more like the blue. That will
more?
tell you about blue poo.
Did you like that? Yeah. It's edible, huh?
So, and then Dylan Baker is my son, and he's a really good software developer, and he has made an app that makes it so that when you eat the muffin, you hit a start, it measures the time it takes, then you tell the app when you're done eating, and you tell the app when the blue poops arrive and when the blue poops are done arriving, and it calculates transit time. So he made this thing, Stripe Symptom Tracker, and it focuses on 4 main symptoms. So bowel movement, pain, as indicated by sort of body position, reflux, and neurological behaviors that were recommended by Dr. Jimenez Gomez, who sees a lot of patients with neurodevelopmental disorders at Joe DiMaggio Children's Hospital. He worked with Jimmy Holder as a resident. And then Barbara Millett is also on the team. She's worked, she is an expert in app interfaces. So, one of the concerns is that if the app isn't designed properly, the responses are going to be biased by how the questions are presented. And so Dr. Millett is helping us assess whether the app is effective. So here, if you selected bowel movement, it would take you to a sliding scale to rate the hardness. It would allow you to enter a description. And, this is something that I think is really important, and that Dr. Bennett also brought up, which is that doctors don't necessarily see patients with Phelan-McDermid syndrome all the time and may not really know the questions to ask. So we're hoping that by having a description, we can get a better sense of what the actual questions we should be asking are, if that makes sense. So sort of a opportunity for feedback. And then there's also a tracker so that there's a calendar view where you can see when symptoms arose and have an expandable view for what those symptoms were. So we are in the, we have recruited, so we have an IRB approval for these tests, and we're just getting going again on recruiting families and starting people on using the app and the muffins to track symptoms in a prospective manner. So if you're interested, please reach out to me. In addition, we have been thinking about some of the retrospective data, and one of the companies that has been trying to harmonize that data is Citizens, that has been bought up by Invitae. And as you know, you guys have a Phelan-McDermid syndrome data hub. What we're hoping to do is try to harmonize some of the prospective with some of the retrospective information. And of course, the hope is to house all this information in a place that's most useful for families. This is the study. So Dr. Bennett has generously agreed to look at the data that we collect. Kara Margolis also, Art Bader, Miranda Van Tilden, and sorry. So these are the sort of people involved. At University of Miami. We also have 2 researchers who are statisticians and have experience in the genetics. And so our goal is to try to use the zebrafish models and the tracker to develop strategies to treat GI symptoms in ASD. And so these are the folks who contributed. I named them as I went along for the most part. And thanks to the funding, and thank you so much for your attention. And I'm happy to answer questions. Sorry for going over.
Thank you, Dr. Dallman. That was fantastic, especially the app I found really interesting just because you can collect a lot of information in a not very invasive way, which is something that we need. So I'm going to spend just 1 minute, possibly even less than 1 minute, and then get to questions. Just talking to you all about this CANDID conference you've been hearing about. I'm going to share just one slide. And I just wanted to just briefly describe what CANDID is. So CANDID is the Consortium for Autism, Neurodevelopmental Disorders, and Digestive Diseases, as Dr. Bennett mentioned, but it's also named to represent some of the somewhat candid conversations that families have around GI issues. So it is June 8th and 9th. It's coming up. To register or for more information, please see our website at candidgi.com. And if you have any questions, please contact at info@candidgi.com. And one thing I really wanted to highlight is that CANDID has come to be due to listening to your voices. So you have told us, and many other people in neurodevelopmental disorders have mentioned that GI disorders are an issue. And this has been a collaborative effort long before I started, which has been brought to you by family members such as Megan O'Boyle, board members of PMSF, such as Dr. Heidi Gravenstatter and Dr. Alicia Halliday, and also Dr. Billy Bennett, who we just heard from, who have all done a fantastic job organizing this. And essentially what it's going to do is bring together families, patient advocacy groups, clinicians, scientists, and industry partners to try to address future work in GI. So it'll start with this conference, but it will continue into the future. So I just want to briefly highlight the sessions. The first will just be a family panel about how GI disorders impact quality of life. We will then be hearing an updated analysis on the pre-conference GI surveys from Dr. Billy Bennett. We will then be hearing from leaders in the fields of gastroenterology, neurology, neurodevelopmental disorders, and data analysis. And this also includes Dr. Julia Dallman. And then we will have scientific working groups who are really dedicated to the future of GI in neurodevelopmental disorders. So we're hoping that this is something that extends not just a couple months from now, but even years from now, which is why we have created a website and a consortium to keep building on this. So we thank you for your input, which has really driven all of this. So with that, I will, I know we're coming up on time, so we're supposed to end at 4:15. If Dr. Bennett and Dr. Dallman have an extra 5 minutes, that would be great. If not, feel free to message in the chat and drop off, but we'll try to get to just a few questions. So the first one here is for Dr. Bennett, which is cycling between constipation and diarrhea classified as IBS, and is it always classified as IBS?
That's a good question. So I would say IBS is probably the most common reason that you would have alternating constipation and diarrhea. But the other one that's probably at least as common is constipation, where you have an impaction or this, big, huge poop sitting in the rectum, and that it stretches the rectum out to the point where stuff just goes around it. And so you have, it looks like diarrhea, but it's just poop that never became poop because there was a bunch of other poop in the way. So usually the way that we figure that out is with an X-ray. And that'll tell you if the colon is distended, if you've got this big impaction in there. And if that's the case, then you have to clean everything out, usually with like a bowel cleanse, like what we would do before colonoscopy, or with enemas. So short answer to your question, yes, but sometimes no. But then also, to make it more complicated, one form of IBS is constipation predominant IBS, where you get really constipated. But I think discerning between those two things, whether or not it needs medication to regulate that consistency, or if you need to clean everything out first, that usually takes an X-ray and somebody who knows what they're talking about.
Thank you for that. So the next question is, if symptoms are not obvious, what symptoms should I be looking for, or what obvious signs should I be looking for if I'm not immediately sure that my child is experiencing GI problems?
So this is a really good question, and it's probably the most common challenge that occurs in children that have limited communication, as is the case in most PMSers. So the way I look at it, there are 3 different symptoms that are your like objective evidence. So one is vomiting. So you really shouldn't vomit. Food is supposed to stay inside your stomach. You have all these muscles there that are supposed to keep it there. So if you're vomiting, then something is up. It doesn't mean it's something terrible, but that's something that should be addressed with a doctor. The second one is abdominal distension. So that and depending on where, and so distension just means bloating. So depending on where the problem is. So if it's in the stomach, and it is called gastroparesis. If the stomach is slow, then all that swelling is from the stomach. If it's from small bowel being slow, like in small intestinal bacterial overgrowth, or SIBO, then the small intestine is really swollen. If it's constipation, it can be air or stool that's filling up the colon, and that can be distended. And again, the best way to figure that out is just with a regular X-ray and with somebody who has familiarity with it doing an exam. The third thing is stool consistency. Do you have constipation? Do you have diarrhea? Do you have some combination of that? Those are the things where you know that it's GI related. The much fuzzier ones are when it's like, you have a child or an adult that is nonverbal who's just upset. And, or, we blame fussy babies. We blame it on reflux and colic and all kinds of stuff all the time. We really have no idea. So I usually take the approach of if you've got somebody with a lot of discomfort and changes in behavior and we don't have a good explanation, then that should start some degree of exploration for a GI cause. So constipation would be like far number 1 on that list. So if you have a child that is fussy and there's not an ear infection, there's not a fever, that kind of stuff, then doing an X-ray or doing an exam to figure out if constipation is present is often a good next step.
Thank you. And I apologize, Dr. Dallman. Most of these are clinical and focused for Dr. Bennett, but we will send you any that we get. We get some questions after the session as well.
I'm learning so much. Thank you.
I'm gonna just ninja defer one to you, Dr. Dallman. I'm gonna be like, oh, this is about motility, Dr. Dallman. All you.
They're all, interconnected, and we thank you for everything that you both are doing. The next one is relatively specific, but may apply to other people on the call. It says that their daughter, whenever she gets a cold or has extra mucus, just throws up all of her tube feeds, and it will take a couple of weeks to be able to eat a full feeding without throwing it up. Is there some sort of medical reasoning for this? Have you heard of this, and what can be done about it?
I've definitely heard of it. I see it very frequently. It is, so the mechanism for that, we think, is that when you're congested, you have a lot more sensitivity to the nerves in the back of your throat and the upper part of, like, where it connects to the upper part of your esophagus. And that's what makes you gag. So you put a finger back there, it makes you gag, and that can elicit vomiting, because that's connected to all of the same mechanisms that control vomiting, like the vagus nerve. So it's all like very heavily connected. So in kids that have sensory processing problems, sort of this extra sensitivity to textures, which is common in autism, then that can sort of basically turn that system on. And then you can have cyclic vomiting that results from that. And what Rika's describing sounds very similar to cyclic vomiting, where there was some sort of trigger, like gagging on the extra secretions you get when you have a cold, that send off an episode. And I generally take a similar approach that I do to cyclic vomiting in that situation. I don't think it's exactly the same thing, but I think it has so many overlaps that we can take similar approaches, which is lots of fluids, give IV fluids if necessary, give Pedialyte to try to get that blood volume up and see if you can turn off the signal. But if the cold lasts for 2 weeks and they're gagging all the time with the cold, I mean, you just have to remove that stimulus. You have to treat the cold, or just be patient. Because I mean, a lot of colds, it doesn't matter what you do, you just have to give it time. But in general, I think being aggressive with fluids is most important too, because it's easy to get dehydrated when you're, especially when you're already sick.
Thank you. This is very informative. There is a question here for Dr. Dallman. It says, I would love to hear more about the blue muffins and the app for tracking symptoms. My son's motility is not great, but due to neuropsychiatric issues, having a motility study is not possible. Is there any advice or suggestion there?
So I guess one of the questions is eating a blue muffin a possibility? And if so, we'd be happy to involve your child in the study, which would mean sending them a muffin to try at home and use the app to track symptoms. The only caveat is that we're still in development. So you guys would be partners in getting the app asking the right questions.
That's perfect. And I think that's what a major theme of the CANDID conference is as well. Something that I forgot to mention related to CANDID that follows really closely with that is with the GI surveys that we're sending out. One of the things that we're trying to do is expose that these surveys are not perfect, especially for people with intellectual disability or who are nonverbal. So if you have ways of improving these surveys, or if you have comments, please send them to info@candidgi.com. So we're really trying to listen to the community and improve these things. Another thing I wanted to mention is a couple questions in the Q&A are focused on toileting. In the interest of time, because we will end in a few minutes, please save those questions because we have a toileting specific session on May 11th with Judith, I hope I don't mispronounce her name, but Kukuvanis, who is a nurse practitioner and has a ton of experience in this area. So that will be fully focused on toileting. And I think we have time for maybe 1 or 2 more questions. And then if there are any other ones, I can send them to Dr. Bennett and Dr. Dallman after the fact and see if they can get you some answers. So let's see here.
And Kate, if you're closing it up on my account, I'm free to answer questions, as many as we have.
Okay, yeah, I also could stay on, so we actually could get through them theoretically if that's the case.
There's a lot of overlap too.
Yeah. Okay. Oh, and we got a response that he can definitely eat a muffin. We would love to participate in the research. Regarding the Blue Muffin Transit Study, can you tell us how to sign up? Is there a place people should look, Dr. Dallman?
So an email went out last year, but we were figuring out logistics a little bit. So I can, if I give you sort of the information, can you post it? Would that be possible?
Absolutely.
Okay, perfect. Then I'll do that as a follow-up.
Great. We have an interested question from Dr. Grabenstatter, who said she'll ask Dr. Bennett a separate time. And then we have a question that says, is there a
For
treatment?
Dr. Grabenstatter, no, I have not seen it in PMS for GI stuff, but we can talk about it.
Okay, so you saw the question. Yes. Okay. Another question is there a treatment or a way to shrink an enlarged rectum?
That's a good question, Dottie. So really the way to treat it is to get rid of the stuff that's dilating it, which is poop. So sometimes it takes a long time for that to shrink though. So what we do is if we see somebody has an impaction, we figure out, well, what's going to work best for them. I tend to do either a Miralax clean out or a magnesium citrate clean out from above. And we just give them the same instructions that we give before somebody has a colonoscopy. And for a colonoscopy, everything has to be squeaky clean so I can see. And in fact, we have to stop them sometimes and just try another day if the clean out didn't go very well. So we use that level of clean out. Because I mean, I want patients to just start over completely from a clean slate and just, and we know that we're resetting things. So until you do that, until you get all the poop out, the rectum is going to still be held open by that big poop. And so typically over, usually a few weeks, but sometimes shorter, that rectum kind of gets back to its normal size because it's not being held open anymore. And then it's a lot easier to sense bowel movements because that what happens when it's distended like that is the inner muscle of the anal sphincter gets held open. And then that's what your body uses to tell if you need to poop. And so you already have somebody who doesn't have good sensory processing and doesn't respond to that information, even if everything's working perfectly. And then you add on having the rectum be distended. And then it just really is a perfect storm for somebody just ignoring the impulse to poop. And then that poop just sits in there, until it gets bad enough that they can feel it. Really the only, like to answer your question, Dottie, really the only way to do it is to flush everything out and start over from scratch and then keep it soft so that it doesn't reaccumulate. There's some kids that where if it's bad enough, if it's like the colon has been distended for months and months or years and years, sometimes it's really hard to get it to go back to its normal tone. It's just kind of stretched out. And those are people that often need surgery, taking out a segment of the colon, or things like the MACE or appendicostomy that I mentioned. I hope that answers your question. Excellent question, Dottie.
The next question is, my adult child's doctor has approved my son to have an enema every 12 hours if he has not pooped. Reason being is he gets extremely upset around the 12 to 14 hour mark. The doctor is wanting 2 large poops a day. If he goes a day without poop, there's an issue and he attacks people. So is this something that you've seen before, suggesting frequent enemas, and do you suggest it widely?
That's a really good question, Kelly. Typically, and I think if you talk to most doctors, like primary care doctors or ER doctors or whomever, they're going to suggest like pretty limited enema use. That's what's on the bottle, and it says, oh, don't use more than 2 of them without calling your doctor. That's not because it's necessarily dangerous. If you give an enema and it doesn't come out, then that can be an issue because enemas are typically sodium phosphate. And if you give a couple enemas in a row and that gets absorbed by the lining of your rectum, that can cause the phosphate level to go up. That is pretty rare. I've never seen it outside of, really young patients like babies, where we don't tend to do enemas anyway. But some brave soul does it, and then there's some serious consequence like that. So other than that, and other than, the child or the patient not liking it because it's manipulation of the rectum, then, there really isn't a downside to it. I have lots of patients that do one every day, and that's how they poop. There's kids with spina bifida that have almost no ability to control that sphincter, that do things called cone enemas, and it's just every day. There's things called there's this special apparatus called a peristine enema that works really well, that's made to use every day. So there's plenty of situations where it's fine. I think you just have to be aware of the downsides, but especially when you're dealing with behavioral problems and you can't find another way to get them to poop on a regular basis, I think that's a great strategy. So I think if it's working for somebody and they tolerate it and it's able to actually produce a poop each time, so it's not absorbing a bunch of extra phosphate, then I usually say that sounds great. I think we have to be creative. This idea that one size fits all for our kids is ridiculous. And it's, most conversations I have with parents are them telling me what a doctor has said, and it blows my mind because they're simply applying, well, this is what the average 18-year-old needs, but there are no average 18-year-olds around here. I mean, like, our kids need more customized and thoughtful care. And that means sometimes thinking outside the box, like doing enemas all the time, even if that's not what we normally do.
Thank you. We just got a question from a staff member that would like to know if Dr. Bennett has experience with using Botox on the inner sphincter muscles to help with emptying stool.
Yeah, we use Botox all the time. And somebody always makes the joke, well, maybe if we're gonna finish all this Botox, can I just take it home and inject it? And I'm like, no. This is Botox for the GI tract, but it's the same exact thing. So we use it in 3 different places. So we use it in the lower esophageal sphincter. So for people that have something called achalasia, where that inner muscle is really tight. I probably use it the most often in the exit to the stomach, or the pylorus, for something called gastroparesis, where the stomach's not emptying well, because it helps relax that muscle. But then it also works fairly well injecting into that inner side of the anal sphincter. And we really just inject it. I mean, it's never something you want to watch a video of, but we just really inject like the whole area with a bunch of Botox, which just really relaxes that, and it keeps it keeps that sphincter from clamping down. I think you want to do it in a center that does it a lot. It's not something that most GI doctors learn in the course of their fellowship. And that, I would say, it's usually more in places that have a motility center that do those kind of things, but it's pretty straightforward. It's not particularly high risk. And as long as the person that's doing it has done it a lot, I think there's some populations that do really well with it. And those tend to be people where the rest of the colon works fine. You just have a lot of issue with it getting out, with that final step of the inner muscle relaxing. But you have to be careful. You don't want to do it in somebody that has a really dilated rectum, because it's just, it's not going to help anything. It definitely requires some specific expertise. And there's probably only a dozen or so children's hospitals in the US that do it pretty routinely.
So I think we have about 3 or 4 questions left. And again, please just let us know if you need to run for either of the speakers. The next question is, our son has CIPO, or I'm not sure if Dr. Bennett called it SIPO. It's hard to find pain relief for him. Is there knowledge about challenges with high tolerance to pain in this area? Also has trouble peeing, but it's hard to get believed for this.
Yeah, well, I mean, I believe the phrase, it's hard to get believed for this. This is a very common experience for special needs parents, is that, I mean, you're watching your kid's behavior nonstop. Like, you're watching the ups and downs. And most of the time, I think ignoring what the parents think is we end up being wrong when we do that. And it's one of the things we always teach residents right from the beginning. It's like, just listen to mom, maybe dad a little bit. He probably can't even name the kids' medicines. And full disclosure, I did that the other day. I got my kids' medicine switched, and then the kids corrected me. So, that was that's a dad type mistake. But I think really the issue that you're describing is, what do we do about pain when nothing seems to help with the pain? So, I think there's sort of two comments I have on that. One is that for GI related pain medicine doesn't work. So if you've got constipation and you give somebody a bunch of morphine, they're just going to have more constipation. And in fact, even for things like appendicitis, it's been shown that morphine is not really any more effective than much less aggressive measures. So the biggest thing is you got to avoid narcotics, because too much narcotic use actually, and Dr. Dallman, I'm sure can confirm this for me, too much narcotic use has a long-term effect on the way that your neuroendocrine and enteric nervous systems function. Was that correct? Did I say that right? Okay. I just want to make sure you guys understand how much smarter you have to be to do what she does versus what I do. I'm a plumber. She's like a professor. So I think avoiding narcotics is important. The second is that if there's pain, to make it better, you have to figure out what's going on. So if there's distension from SIBO, you have to treat that. Nothing's going to make that pain better unless you can get rid of that distension, which usually means antibiotics. And the one that we use most often is called rifaximin, probably the most effective. If that's not available, the second best one is called metronidazole. It's much cheaper. Rifaximin is very expensive. And then as far as your question about pain from peeing, that, urinary retentions, I know that's not my area of expertise, but that's a big issue in PMS, and it's very, very painful. And so if somebody hasn't peed for a while and they're in a lot of pain, that's a good reason to go to the ER. And sometimes they need to have a catheter placed, temporarily, just, like for a minute to get the urine out. I hope that answers your question.
Any changes we should be watching out for in early adult years? If a cat full of Miralax is not helping, what is the next step? Typically 5 to 7 days between bowel movements.
Okay, this is a good question. So really, you want to do two things. So you want a musher and you want a pusher. So the musher is the stool softener. So there's stool softeners, which are Dulcolax. Colace is your stool softener, and then you have what are called osmotic laxatives. That's Miralax, lactulose, those kind of things, where it draws more water into the stool. And then you have stimulant laxatives, so Senna, X-Lax, Dulcolax. So the first category is the mushers, and the stimulant category is the pushers. So the first thing you have to do is make sure that you're using enough of the musher. And so, like, I usually start by going up on the Miralax and seeing if you can do it with just Miralax. And then once the stool is more soft, and then it's a lot easier for the pusher to work. So I usually go up on the Miralax or whatever the musher is, and then until I get the poop nice and soft. And then if there's still a long period of time between bowel movements, that usually means that there needs to be another push to get things done, and that's when I usually start Senna. And these things come in rectal suppositories as well. You can either do an oral stimulant laxative or a rectal stimulant laxative. But that's usually what I start with. And if that doesn't work, if aggressively trying those two medicines don't work, that is when somebody needs to have a motility evaluation.
The next question is if you see gastropathy a lot in PMS, and I'm not sure, forgive my ignorance, if gastropathy refers to reflux or other things related to the stomach, but not sure what falls into that category, but do we see it a lot in PMS?
So we see it a lot in everybody. So gastropathy is kind of a catch-all term for injury to the stomach. And then when you go in and you look with a scope, you see a lot of sort of tissue that has had to regenerate. It can happen for lots of reasons. The most common reason is acid. So we often see it as being a consequence of acid damage. There's lots of other things that happen to adults. So alcohol can do it, but I don't think that's probably a big problem in our kids. Really bad malnutrition can do it. Some infections can do it. But I see it most often, related to acid. It's probably more common in special needs kids that have underlying neurodevelopmental disorders in general, because they're often not reporting that their stomach hurts. And so you may not catch that until later. So I think for that reason, a lot of patients with PMS are on acid medicines. And I wouldn't be afraid to use them. There's plenty of stuff on the internet that would have us be deathly afraid of these medicines, but I've seen bad GI bleeds hurt or kill many, many people, and I've not seen PPIs kill even one person. So it's all about risk and benefit. Every medicine has side effects, but you got to decide, are these side effects worse or better than the thing you're trying to treat? And unchecked acid damage is something that I've seen cause very bad things many times. And so that's just something to remember.
Okay, second to last question. New to this awesome community, wondering if there's a specific guideline to give our doctors and specialists how to test our children when they're facing situations. This seems to be when the doctors aren't listening. How do I tell our GI specialists what to look for when our daughter is constipated? Our daughter is 30 years old and they don't take the time to research what PMS is, which I think is very common across many issues in PMS.
And that's true for probably every rare disease. I mean, even not nearly as rare, diseases that affect development, like Down syndrome. There's plenty of doctors that don't treat kids that have a rare disorder any differently than kids. I'm a pediatric gastroenterologist, so I refer to all patients as kids, even if they're 38. So just, I'm not usually giving advice just for children or just for adults. It largely overlaps, considerably. So easy answer to your question is that we're almost done with the GI clinical practice. I mean, with the updated PMS clinical practice guidelines that encompass all specialties. And this is a much bigger undertaking than in the past. We've got a couple dozen people contributing to it who are clearly the most expert at all of these sort of things. It will surprise no one to learn that I'm in charge of the GI part of it. That's something that we're hoping to have out later this year. And we'll make sure that's disseminated to the community. And you can just bring a copy to the doctor and be like, here is the clinical practice guideline from the experts. The other thing is that most of us on the medical advisory board are very comfortable with doctors reaching out to us, patients too. So if there's somebody, if there's a situation where you think that talking, a GI doctor talking to me or somebody else that has a lot of PMS experience would be helpful, I, for one, am all for it. I do it probably once a week. So, if you need a more direct line, most doctors are pretty open to talking to other doctors with specific expertise.
Perfect, thank you. And this is the last question. And I apologize if by any chance I missed any questions. Please email me directly at kate@pmsf.org and I'll make sure they get answered for you. But the last question today is, and this might be similar to some of the other questions, is my adult son has stopped using the toilet to poop, instead holds poop and will release it at night while sleeping into the depends. And it's a large poop since it's accumulated for a day or so. Should we be taking action to have his bowel movements more frequently and smaller?
So I have two thoughts on that. So one is that pattern you're describing is almost always behavioral. So once he's asleep and can't hold it anymore, then his body's like, yeah, we got to get this out. So because it's behavioral therapy tends to be pretty effective for that pattern. There's a lot of ABA therapists that have taken care of PMS kids, and we've got we have some ABA therapy stuff coming up in the new guideline. But, just, frequent toilet sitting and, many attempts during the day to try and pass a bowel movement, ideally after meals. That's whenever there's a reflex that goes from your stomach to your rectum called the gastrocolic reflex that tells it to move on, move stuff on through. It is that's somewhat impaired in PMS, but it's probably the strongest, and fastest GI reflex, at least that we notice clinically. Like the urge to go poop right after you eat dinner sometimes is dramatic. So we try to make use of that by having people sit after meals to poop. The other thing that you can do in that situation is do like a suppository, either usually like a glycerin suppository, which is just like, the slippery part of soap, and that just helps relax the internal sphincter and initiates a bowel movement. It doesn't hurt you to poop once a day, and as long as it's not like this huge disruption to clean him up after he's already asleep, which I imagine it is, then what you're describing from a GI standpoint is a completely normal pattern. So this is what Cecilia does, for instance, my daughter does, and she's 6, and she's perfectly capable of pooping, but she doesn't want to. And when she gets home from school, she just, she's like watching a show or something, and she poops, always within like the same hour. And that's the time that she poops. It might just be that your son, right, as he's falling asleep, that's when he wants to poop. So I wouldn't say that's an abnormal pattern unless it's causing some distress to the family or to him. But pooping once a day is, even just once a day is completely fine.
Thank you so much. I would like to thank both of our panelists for staying after and for answering questions. I think this has been a really informative session. I know I learned a lot. And thank you everyone for attending. And the recording will be available in the app in the coming week. And if there are any other questions, please email me and we will get them answered. Thank you very much.